Okay, so thanks very much for the introduction. So I'm speaking today on behalf of the Campaign Spinal Cord Injury Development Group. And so as mentioned, I'm going to be speaking on the management of neuropathic pain after spinal cord injury.
Sorry to interrupt you, but would you be able to put it on full screen?
Yes. Oh, yeah, you know what? It's not working. Oh, sorry there. Can you see it better?
Yeah, thank you.
Okay, perfect. And specifically, I'm going to be talking about the Campaign Spinal Cord Injury Clinical Practice Guidelines. So before I get into it, just to give a little bit of background and rationale as to why these guidelines were developed. Really, it's because we know that neuropathic pain is highly prevalent following spinal cord injury and has a really large impact on people's lives. But there really was not any standardized guidance as far as how to manage neuropathic pain after spinal cord injury in the form of clear recommendations. And so we did feel that there was really a need to develop these guidelines. And so there's been a number of studies that highlight this. One is a study that looked at 12 different Canadian spinal cord injury rehabilitation sites. And what was found that of these 12, 9 of these sites had no standard of care and no treatment guidelines of any form for actually selecting treatments for neuropathic pain after spinal cord injury. In addition to that, if we look at actual responses from clinicians, there's been a number of studies that have been performed on clinician needs analysis. And this is one that I'm highlighting out of Australia. And what they found is that the vast majority of clinicians felt inadequately resourced to manage post-spinal cord injury pain. So this led to the development of the Campaign Spinal Cord Injury Clinical Practice Guidelines. And so the main purpose of these guidelines was, one, to create practical, actionable guidelines for the management of neuropathic pain after spinal cord injury. 2, to support standardization of care in rehabilitation. And 3, also to identify opportunities for further research. So where are there gaps in our current treatment research? And one thing else I'll mention here is that there are a couple of publications. So I'm going to give an overview today on these guidelines, but if you'd like to dig deeper and get further information, we have published our original guidelines back in 2016, and this is available open access in the journal Spinal Cord. And then more recently in 2021, we published an update to these guidelines, and this is also available open access in Spinal Cord. Okay, so for the talk, I'm going to start off just by discussing a little bit about the development of these guidelines before getting into what the key recommendations actually are. And so these are going to be recommendations related to how neuropathic pain should be screened and diagnosed after spinal cord injury, what treatments should be selected, and also some information on models of care. And then I'll finish off just with some future directions. So where we're at currently with these guidelines and where we plan on taking them. Okay, so to start off, just a little bit about how these guidelines were developed, the people involved in the review process, including the 2021 update. So it began with the development of the steering committee. So this is a smaller group of healthcare professionals and researchers. We're housed out of London, Ontario, Parkwood Institute, but we have members across Canada and the United States as well. And so the role of the steering committee was to kind of guide the entire process of developing this guideline, and also to work to assemble the working group. And so this working group is composed of international experts that specialize in pain after spinal cord injury. And so they come from a variety of different disciplines: physiatry, psychology, neurosurgery, research, allied health and nursing, and pain medicine. And so these individuals, then, they were taken in based off of their area of expertise as well as logistical factors. They were split into one of 3 groups. So either they focused on developing recommendations for screening and diagnosis, recommendations for treatments, or recommendations for models of care. So as for the actual process and of developing these recommendations, the first thing I'll note is this was all done under the framework of the AGREE reporting checklist. And so what this instrument is it's been developed to help address issues in variability in guideline quality. So basically, it just means when you're developing these clinical guidelines, this is a means, it's kind of a strict means of ensuring that there's methodological rigor and transparency in the guideline development. So what happened is the first thing we did was we had the working group develop a list of questions that they felt were necessary to answer in order to come up with their recommendations for each of the 3 topic areas. So those questions were then given to the steering committee, and we created a search criteria and performed a systematic literature review to help answer these questions. And so this literature review, it involved studies that utilized at least 50% of the population had spinal cord injury. They all had neuropathic pain or mixed pain. And importantly, the key outcome was pain intensity. So after performing the literature review and deciding on which papers would be included in the study, there's then a quality assessment. And so this is done through what's known as a grade approach. So basically, every study is graded from high to very low based on a number of factors, things like study design, imprecision, inconsistency, indirectness, and bias. So after the papers were finalized and the papers were graded for quality, that's then sent back to the working group. And this is when the working group would actually develop their recommendations. So they would apply a recommendation of either strong or weak. And this is based off of the quality of evidence. So how strong is the study, but also a number of other factors. One being, for example, the efficacy of the treatment versus the side effects that may be associated with that treatment. Some more subjective things such as values and preferences of the clinicians themselves, and then also cost. So how expensive would the treatment be, and then what other resources, personnel, and equipment are required to perform the treatment. So after the recommendations were developed, they would then be sent to the entire working group where they would be discussed. And after discussion and anonymous voting, if a recommendation achieved at least 75% agreement from the entire working group, then they would be finalized. And then the last steps to send the entire process for external review. So 3 external reviewers would assess the entire process, again, looking for methodological rigor and transparency. And then when that passes, then the guideline moves forward. So it's quite a rigorous process. And again, this was repeated for the 2021 update. And so I'm going to discuss now some of the key recommendations, the findings that came out of these guidelines. And this will be those including the 2016 guidelines as well as the update added on. Okay, so we'll start off by talking about some of the key recommendations for the screening and diagnosis of neuropathic pain after spinal cord injury. And so what came out of these guidelines is 15 recommendations on how to screen and diagnose neuropathic pain after spinal cord injury. And I'm not going to go through all of these in any detail. I will mention that if you're interested in the guideline themselves, these are explained in much more detail. They give thorough explanation of exactly how to go about doing screening and diagnosis. But just to give a very brief overview, generally what we have in these recommendations are items related to who on the healthcare team should be performing the screening and diagnosis, how they should be going about performing the screening and diagnosis, and when and how regularly they should be performing reassessments. There's also items related to specifically what tools are appropriate for diagnosing and for screening for neuropathic pain after spinal cord injury. And then lastly, importantly, to assess for any red or yellow flag conditions. And so these are red flag conditions or any serious underlying conditions that can aggravate or mimic neuropathic pain. So these are things that are in need of prompt medical review. And then there's also yellow flags, and these are more psychosocial factors. So maybe depression and anxiety tied to neuropathic pain that can contribute to distress and disability. Okay, so touching on then some of the specific treatment recommendations that have come out of the guidelines. And so I'll mention first, these treatment recommendations are split into first-line treatment options and non-first-line treatment options. And so again, these treatments are split in this way based on the quality of evidence. So first-line treatment options are typically coming from studies that have strong designs, randomized control trials that were well run. And also coming from a strong recommendation from the expert panel. So they felt that they were effective, had low side effects, and the cost and resources were appropriate as well. So the first one, and I will mention too that, so these were initially established in the 2016 guidelines, and then after 5 years of further research, they remain the #1 choices. And that being because these two, which are gabapentinoids, have the strongest evidence for efficacy. And then in addition to that, they both are associated with only mild to moderate and predominantly transient side effects. So side effects associated with these are typically things like somnolence and dizziness. So another treatment also that is considered first-line treatment for neuropathic pain after spinal cord injury is the tricyclic antidepressant amitriptyline. And so this one is also a first-line treatment based on the quality of evidence, strong studies showing that it is effective for reducing neuropathic pain. But one important note and one thing that we point out in the guidelines is this has been intentionally separated from the initial two treatments because it does have a more severe side effect profile. And specifically, this can have anticholinergic side effects. So it can induce things like rapid heart rate, urine retention, constipation, digestive issues. So things that can be a concern for spinal cord injury. So it's important to note, although this is a first-line treatment option, it should really only be used if the gabapentinoids have first been attempted and proven effective. Then you could consider moving on to amitriptyline. And then there's the non-first-line treatment options. So I'm not going to go through all of these in detail, but so we have categorized these into B, C, and D options. And so again, these are categorized based off of the quality of evidence, with B options having higher quality studies than C or D options and stronger recommendations from the expert panel. But one thing that's important to mention is that when you move from the first line treatment options onto non-first line treatment options, the literature is far more sparse than they are for first line. There's not that many studies that have been done on these treatments. And so for that reason, although they're categorized this so that healthcare workers can be aware that there is more evidence for the B options, it is suggested that there should be some subjective nature into which treatment you select. You don't necessarily have to exhaust all B options before moving on. And so instead, this can be based off things like patient preference, clinician experience, accessibility to different treatment options. And then one other thing that was actually added recently in this 2021 update is this list of general treatment principles. And so the reason that these general treatment principles were formalized in the latest update of these guidelines is again related to the fact that for non-first line treatment options, there is not a lot of evidence. There haven't been a lot of studies for these options. And so in brief, what these general treatment principles really try and get at is the importance of encouraging self-management strategies among patients. And so that being, if a patient finds that a strategy is beneficial for reducing pain intensity or helping them cope with pain or improving function, then really regardless of what the evidence of the literature is, if it's deemed appropriate and safe by the healthcare team, then it should be something that should be promoted. So for example, things like exercise, stretching, meditation, that don't necessarily have concrete evidence in the literature to suggest that they can effectively reduce pain intensity in neuropathic pain, but should still be promoted if patients find that it is beneficial to them. And then kind of a second primary point from these general treatment principles is the importance of utilizing a comprehensive pain management strategy. And so again, that comes back to not simply focusing on treating pain intensity, but also focusing on trying to improve mood, sleep, activity, things that can be hindered from the pain and also contribute to pain as well. Okay, and then finally, I'll get into the models of care recommendations. So the models of care recommendations relate to principles of how care should be delivered for people with neuropathic pain after spinal cord injury. And these are of particular importance also because it is important to note that unfortunately it's not always a realistic goal to expect complete alleviation of pain. And so in saying that, then it's important to address, again, not only pain intensity and focus all treatments strictly on trying to reduce or eliminate pain intensity, but also address functional and psychological impacts of pain as well. And so in doing so, a team approach is really important. this team approach in order to help improve timelines, health outcomes, better patient satisfaction, and more effective resource utilization. Another item that came out as a recommendation was the importance of considering alternate communication methods when distance may be a barrier. And so this is actually one that was formalized back in the original 2016 guidelines. But of course, now over the past 2 years with the COVID pandemic and the need for social distancing, this one has become particularly relevant. And then finally, the importance of recognizing kind of when it is time to discharge patients from specialized care. And so again, when maximal gains seem to be achieved, when there is a stable plateau in improvements of pain symptoms, and it may be time to discharge patients from specialized care. Again, coming back to the fact that 100% alleviation from pain is oftentimes not a realistic goal. Okay, so those are the key recommendations that have come out of the guidelines. And then I'll just touch on some of the future directions that we want to take the guidelines in. And so this relates to beginning to update the guidelines through what is known as a living guideline approach. And then also taking this and actually integrating this into clinical point of care. So first, this living guideline approach. I'll say a major limitation of any clinical practice guidelines is keeping them continually up to date with recent literature. And so what you'll typically see in a traditional approach is that guidelines are updated every 2 or 3 years or so. And this gap between updates means that you really kind of build up a high volume of literature, and it can be a pretty onerous process to go through the entire systematic literature review process, screening all of the papers, appraising the new evidence, and then having the expert panel take a look and come up with new recommendations. And perhaps the biggest issue with this is that oftentimes your recommendations from your guidelines are 2 or 3 years old and outdated. So an alternate approach to this is what's known as the living guideline approach. And so essentially what happens with a living guideline approach is that the literature reviews are kind of continuously performed. We would update our systematic literature reviews on a continuous basis and then present those results on an annual basis to the working group so that they can then take a look and create new recommendations and update the guidelines. So this kind of leads to, it's an ongoing process, but it leads to a lower volume of literature at any given time, so it is more manageable. And then most importantly, it leads to much more current and up-to-date recommendations. And then the final thing that I'll touch on today is just our plans to try to actually integrate this into clinical care. So right now we are actually working on taking these guidelines. We've created an algorithm for the screening and diagnosis and treatment recommendations. And we're developing mobile and web applications. And so what this will allow is for healthcare professionals to use these apps to help to diagnose pain. So what type of pain it is, whether it's nociceptive or neuropathic, as well as specific types of neuropathic pain. There will also be prompts for assessing new and worsening pain and those red and yellow flag conditions that I discussed. And then so based off of the results from the screening and diagnosis, then it can take you through a specific treatment program where it will recommend which treatments should be tried. So this is where we're at. We've got the algorithm produced. We're in the middle of producing these applications, and then we are teaming up with our team at Parkwood Institute, as well as some team members in Quebec to get it on and rolled out there as well. So with the goal of getting some feedback from clinicians so that we can kind of further refine the tool, and then ultimately the goal is to expand this to a provincial and then eventually national implementation strategy. So that's kind of the overview of the campaign guidelines, and happy to take any questions that anybody has.
Thank you, that was awesome. I do have a couple. When speaking about pain, is the sense of crawling electric buzz considered pain? People I know keep their limbs cold to slow that down, but I wonder if there's anything else that can help.
Yeah, I mean, I suppose it's a subjective thing. So if it is considered a painful experience, then it would be. I am not. I'm not sure of a specific treatment strategy for that off the top of my head.
The next question is, were there any differences, or sorry, were there any difference of using Elavil versus nortriptyline for efficacy and side effects?
Yeah, let me just come back to this. Sorry, can you repeat that? Which treatments you were looking at? Lamotrigine, you said?
It says difference using Elavil versus nortriptyline.
So those weren't those two weren't actually included in our first line and second line treatment options that I had discussed.
Can whomever the poster of that question, if you have anything else that you wanted to ask around that, feel free. Dr. Charbonneau just responded that Elavil is amitriptyline. Nortriptyline is a TCA with less anticholinergic side effects.
Okay. Yes, I don't believe that we have anything specifically on that to compare to. Amitriptyline was the only tricyclic antidepressant that we had included as a first-line treatment or as a second-line treatment. We have, I haven't kind of gone through all of the options. We have a list of options that were not considered for first or second line treatment options, just again, because of, primarily because of the scarcity of research right now. So that was not one of the ones that was included in these guidelines.
Okay, great, thank you. That's all the questions that I have written in there for now. And I will pass it over to Casey to introduce our next speaker. And thank you, David, so much. That was great.
Okay, thank you.
Thank you.
Thank you, Anna. Thank you, everybody, for your questions. This is a surprise. We are actually running a few minutes ahead.